Good evening. Namaskar. I'm Dr. Talwar. I am head of IVF department at Sika Birla Hospital at Gurugram. In the times of this lockdown period, we have been communicating with each other nearly every week with some topic of interest pertaining to IVF. Today's topic of deliberation would be recurrent abortions after IVF. Before we go to the main topic, we have to understand certain things, and these are that IVF per se by itself is a very expensive, it's a psychologically disturbing, emotionally disturbing condition. Here, the patient is having a lot of physical distress and he behaves very abnormally in case the results are not good or in case something goes wrong with the whole cycle. The whole of IVF procedure is highly uncertain and we barely get around 40% of the result when we carry out IVF even at very good centers. After a lot of counseling, after a lot of deliberation, the couple undergoes an IVF, and what we find is that the patient conceives. That's a time of celebration, but unfortunately, that the whole thing ends up in an abortion. One ultrasound is carried out by the doctor, and the patient is told that you are having an abortion or you don't have a proper heartbeat. This is a very heartbreaking information for the patient, and it doesn't only affect him or her, it affects the whole family, the parents, in-laws, the whole family is actually disturbed. The whole family goes into depression, and again the whole thing starts. Multiple visits to the hospital starts again, and the patient visits the gynecologist for repeat ultrasounds, and he's given multiple drug therapies, or he undergoes some sort of DNC or an MTP to get rid of the pregnancy which is not progressing properly. So darkness is all around, and the patient, the couple, the whole family goes into a shell of grief, and they are highly mentally disturbed. This thing happens once, it's okay, but in case it occurs again after some time, that is highly disturbing, and the couple is even more disturbed. And sometimes they give up on the life, and they feel that the life has ended for them. They are totally broken down. So now, what does the patient do? He normally starts blaming themselves. They feel that they have done something wrong, which has led to the problem, or they start blaming the God. They say that God, why is it happening with us when everyone else is doing so well? Why is it happening with us? So they start thinking what to do. So the future is uncertain. Many of the people they come back to the doctor and undergo a repeat IVF done after a good amount of counseling. Some change the doctor, they change the hospital. Some they go to a new religious place and take blessings of God. And some feel that okay, now I'll undergo some sort of embryo donation or an egg donation or sperm donation and try the whole thing again because I'm not conceiving, and even if I conceive, I'm having recurrent abortions with my own embryos. So there are multiple questions and there are multiple answers. So the last thing which we need now is is bad information and information which is not correct and which is depressing for all of you and also for all of us. So there are certain myths about recurrent abortions. When recurrent abortion is a term which we use when the couple has got more than two abortions. After the period of these things can occur. This can occur after the presence of the after the heartbeat comes, and they can also occur after the fetal before the fetal viability has occurred. So there are certain myths about the recurrent abortions. First of all, many people feel that whatever science may say, it is a God's curse. God doesn't want us to conceive, and so they go into depression. Some feel that there is no treatment for this thing at all. We have tried a lot of drugs, a lot of medications. Now there is no treatment, so we can't move further. Some people feel that probably I walked very early after the embryo transfer. I ate some particular type of food which gave me the problem. Some say that I went and did some yoga, I did some meditation. Some said, okay, I slept at home, I fell down, or I broomed the floor, or I cooked in the kitchen. So there are multiple things which come in the people, but there is no concrete answer why the whole thing is occurring. So something I did is in back of the mind for everyone. Grief is a normal response of the whole condition. Uh, Grieving is in a different way. The lady will grieve in a different way. The husband would do it in a different way. Our relatives, the people around us, they behave differently, and our parents, they behave differently. Remember, the people who are very close to you, they normally they go into their own shell. They won't like to talk to us about the problem, feeling that in case they talk to us, they'll probe us, and this will give us more pain. So we may feel that okay, they are becoming very cold to us, and that puts us into more depression. So finally, it is, I think, it's our own battle. It's our own battle as a couple, own battle as the mother, and the grieving of the mother is very different and very sensitive from the grieving of the people around. Spouses, the husbands have their own way of keeping quiet and supporting you. This point of time, I think, is the time to take good care of yourself, and all of you should wake up to one point that the recurrent abortions are not always occurring, and I think we can always correct in case we find the right reason of the recurrent abortions. Before any decision that okay, we won't go ahead with the treatment, I think you should visit a good doctor and take some sort of basic treatment from them and understand why this thing has occurred. So now we'll start with the main topic of discussion. I have already got around 10 queries from all of you. We'll take them later. So in the upcoming next half an hour, we'll define certain things. We'll know about recurrent abortions, and then we'll go to the Q&A session. So first of all, what is a recurrent abortion? This I've told you that more than 2 or 3 abortions, one following another in a couple. And here we're talking about IVF. So in case we have done 2 or 3 IVFs, and every time, probably when the heartbeat has come, but the pregnancy is not progressing further, we call it an recurrent abortions. We have to also know that nearly 70% of the pregnancies, they go unrecognized and they undergo abortion. 70% of the times when the couple conceives, they may undergo abortions, which they cannot even know that they have aborted. And nowadays, with the advent of the good ultrasound machines and availability of good the diagnostic methods like beta HCG, we are able to diagnose a pregnancy earlier. But in the olden times, no one even knew that they have conceived and they used to abort. Then, in case a couple has conceived after the IVF or even naturally, you'll find that 10% of the pregnancies can end up in abortion. So that is the abortion one. And in case one abortion has occurred, there is a chance of having the second abortion more than the first time. And that comes to the term to nearly around 15%. And the third abortion may occur in around 30% of the couples. And in case the 3 abortions have occurred, the chances of the fourth abortion may be around 50%. So now coming to the common correlations, why does the abortions occur? What are the common conditions? Now let's go one by one, and we find that the common conditions which lead to abortions are the people who take a lot of tea and coffee. It's a known thing that in case the caffeine intake is very high, the chance of abortions are more. So whenever we are undergoing some sort of IUI or IVF procedure, we have to ensure that we don't drink coffee and tea in excessive amounts. That should be in fact stopped. The second reason of having such sort of abortions may be having high amount of alcohol intake. Taking alcohol uh, regularly and in high amounts can also lead to abortions. And third is smoking. Smoking is definitely one of the very big causes of abortion. So anyone who's having recurrent abortions, we would like to tell you that don't smoke, don't take alcohol, and don't take tea and coffee. These are the few things which create problems for all of us. Then certain drugs, in case we take routinely, we take drugs which are some painkillers or antipyretics which we use to treat fever. All these things can lead to problem. And then there is something called stress, which is very common in all of us. So in case we are we worry, we have a lot of things in our mind which are working around the clock. They can also lead to abortions, though it is not documented fact, but abortions may occur with the high amount of psychological stress. And in case a patient is having some sort of old medical problem like diabetes, hypertension, then also there is a chance that there can be chances of they're having an abortion. Okay, now after we have spoken about these things, we go to certain other factors which can lead to abortions. There can be some sort of an hidden infection in the vagina or in the cervix, which is untreated. So such abortions can also lead to the problem. So we have to ensure that the woman is not having any sort of subclinical vaginal infection. So that has to be ruled out. And then we have certain issues like age. Now, age is very important. We have to know that the women who are less than 35 years of age, they have less chance of having recurrent abortions. But as we cross age of 40, the chances of abortion they increase and the problems are they become multiple. So we have spoken about the lifestyle diseases where there is smoking, alcohol, then there can be some other type of drugs, stress. All these things are leading to the problem. We have spoken about maternal age, which is very important. There can be old problems in the couple, medical problems like diabetes, hypertension. They can be an issue. So all these things have to be properly worked out, and proper treatment has to be taken in case a woman has any abortion. In fact, before we have an abortion, we have to see to it that these things are done, these things are eradicated before we go in for IVF or IUI. So there are multiple reasons uh, beyond these things, and one of the commonest conditions of abortions is some sort of anatomical problem in the uterine cavity. The uterine cavity is unhealthy. The uterine cavity has got some sort of partition or some septa inside. Septas are small muscular partitions in the uterine cavity. When we have them, there is a chance that abortions may occur. So, or there can be a polyp or any growth inside the uterine cavity, which won't allow the fetus to implant, the baby to implant well. So that can end up in an abortion. The other conditions which we commonly find are the genetic. There may be some sort of chromosomal problem in the both male or female, or either in male or in the female. So when there are chromosomal problems, the number of chromosomes which are there in the embryo, they are not in the right number. So these we call as aneuploidies. When aneuploidies they occur, or the chromosomes are not fully moving on from after one division after another, they are called translocations. When these things occur, again, there's a high chance that abortions may occur. Then the other conditions which we commonly find are the conditions which are endocrinal. So a couple having a thyroid problem can also have abortions, because thyroid hypothyroidism, when the levels of thyroid go very high in the body, abortions may occur. So it is our duty as an ART clinician, and it's your duty as a patient. We have to ensure that before we start any treatment, there is the thyroid problems are adequately treated. Then there are conditions like PCODs. PCODs are pretty common, and we routinely talk about them. When a woman has got PCOD like ovaries, and the ovaries are big, there is some the PCODs are commonly associated with the abnormalities of the blood glucose, and it can bring in diabetes. So when the PCOS is there in the woman, there is a chance, it's a correlation that there can be abortions as compared to the other women. Then there are causes, autoimmune factors can be there. These are some are genetic, and some occur in the body as the age of the woman grow. So we have to know one thing. One important thing which can lead to all the problems is APLA, that is antiphospholipid antibody syndrome. This is a condition which is fully treatable, and this very commonly leads to abortion in a couple. But we'll have to one important thing which we find in the people is that when the couple has got a condition which are associated with obesity, personal habitus, the personal physical build of the woman. When her BMI is very high, she's obese, then again the abortions can occur. But on the other hand, when we look at the whole data, we find that the people who have got who don't have these conditions, so they're still having abortions. So we call them unexplained abortions. So majority of the people fit into this criteria in which there is no cause found. So between 40 and 60% of the people, they don't have any reason of abortions, and we call it unexplained recurrent spontaneous miscarriages. This is a very common condition, and we have to look at it that way. So moving further, there are some conditions about which we know, there are some conditions about which we are not aware of why this thing occurs. But one thing is for certain, we shouldn't become disheartened, and we look when we get a patient with recurrent abortions, or in case you are having these problems, it is quite a lot treatable in case done in an appropriate way. So how do we evaluate a patient? Till now, we have spoken how we feel in case we have a pregnancy loss after an abortion, after an IVF, how bad we feel, and in case we have multiple abortions, we feel actually worse. So now we come to how do we evaluate. We have seen various causes which can lead to abortion. Now we're looking at the evaluation of the patient. So we have to do very basic treatment and basic investigations. First of all, as we have spoken, that we have to ask the woman that how many times before she has had abortions. Is it the first time, second time, third time, fourth time? This is very important for counseling part. I mean, we have to counsel them appropriately. Then after this, when we move further, we have to look at the age of the woman, and appropriately we have to counsel them. When the age is less, there's a high probability that the woman will abort, and when the age is okay, when the age is more than age more than 40 years, the high chance of her having abortions are there, and age less than 35 years is the right appropriate age for the woman, and the chances of abortion are less at that age. Then her BMI, her weight gain, body's weight gain. BMI is an index by which we come to know how we correlate her body's height with the weight. In case the BMI is more than 27 or 28, there is a more chance of her having an abortion. Certain tests are to be carried out. So when we get a woman who's got abortions, we have to always we have to carry out certain tests. The most important test here, after doing her blood sugar, glycosylated hemoglobin, and other tests, we have to do her thyroid profile. Thyroid profile is very important, and it is a known case of abortions. Then, whenever a child has conceived and it aborts, there is a probability. Many doctors, they carry out genetic analysis of the products of conception that can be carried out. But these are a debatable things. So, but many people do carry it out. Then there can be parental karyotyping done. Here we take the blood of the couple and we look at the chromosomal count in them, and we look at the various, we look at how the chromosomes are behaving. Are they normal or they are abnormal? We can carry out an ultrasound for them to look at the uterine blood flow, we look at the uterine shape and the volume. And in case nothing works, then we also carry out hysteroscopy and laparoscopy, which is not routinely recommended. So we have to also remember that one very common thing which we have to rule out is antiphospholipid antibody syndrome. We call it APLA. And for the APLA, what we do is that we carry out for the patient some blood tests, and that they're basically for ACA, LAC, and lupus anticoagulant, ACA. These things are being tested. So after this, now we are moving to what should be done and what should not be done. So what are the recommendations? So in case you have had two or more abortions and you visit the gynecologist clinic and you want to know from the event and you want to know what I should be doing. So what happens here is very commonly they order for you the fetal products karyotyping. So they say that since after you undergo an abortion, we'll take out the tissue and send that tissue for karyotyping. So you have to know that this is not a highly recommended test. And as I've told you, that majority of the people who abort, they may be having some sort of chromosomal problems. So it is not recommended that you should send in every woman the products of conception for karyotyping, because it is a very expensive technique, and it doesn't give us much idea too. But in case we carry out products of conception analysis, there are multiple methods of doing that. An older method was called FISH, FISH. In this particular technique, we basically map the chromosomes of the couple and look at the number of the chromosomes the number of the pairs of chromosomes are mapped, and we find that this is a very low efficiency test because it can check normally 5 to 7 chromosomes only. So what we recommend is that in case we have to undergo some sort of genetic analysis, we have to do a thing called array CGH. This is a very good technique and gives us a good outcome. In case possible, we have to go in for next generation sequencing, that is called NGS. So in case we have to undergo genetic analysis of the tissue, the products for conception, we should be going in for array CGH or NGS and not FISH. This would be a take-home message for all of you. Now, coming to the other factors, as we have found that the chromosomal causes in the fetal tissue are normally present, and we don't recommend it doing in every case. It may be done for some sort of research or some prognostic factors can be judged. Another test which is normally ordered is the karyotyping of the couple. It is said that we take the blood of the mother and the father, and the chromosomes are mapped. So chromosomal mapping is done of the couple, and this again is conditional. Though we do it in a lot of couples, and it's not indicated in all. But I still feel that in case a couple has got more than 2 abortions, the karyotyping can be done. So it's a very simple test. Blood is taken, and then we get a report after 4 to 5 days, and the chromosomal mapping is done, and we come to know whether we are having any chromosomal issues or not. Coming to the endocrinal reasons which we normally face, one is the PCOD, then there can be thyroid problems, uncontrolled diabetes, and the luteal phase defect. So PCOD we have already discussed. PCOD ladies are more prone to having abortions. It is as per the guidelines. Yes, they can have more number of abortions, and so I think we should know in case a woman is having PCOD. That is more important. And then to treat, what do? We normally give them tablet metformin, 1 gram per day. So metformin can lead to the regulation of the PCOD, which has got an hormonal imbalance. So PCOD, along with the PCOD, there can be certain things like her insulin levels may be high. She may be having insulin resistance, or her fasting insulin may be very high. So all these things can also be done, but they are not appropriately documented. The important thing is that in case a woman is having PCOD, these tests may be done, but not mandatory. What is important is that we just put her on metformin, and this will help her in reducing the number of abortions, though it needs more corroboration from more studies. Then coming to the thyroid, this is one condition in which we know that when a woman has got hypothyroidism, the problems can multiply, and the woman can have recurrent abortions. So for thyroid, we have to carry out thyroid screening by doing TSH and TPO antibodies. So whenever a woman has got RPL, recurrent pregnancy loss, we should do TSH and TPO antibodies. And in case the woman has got abnormal TSH, then we can always put them on minimal dose of altroxin, which we normally start at 25 micrograms per day in the morning, empty stomach, with a sip of water. And here I would like to also add that the altroxin, we have to achieve the level of TSH to somewhere around 2.5. So that is our endpoint of giving somebody the treatment with altroxin. So there is not much evidence of trying to reduce the levels of LH in PCOD patients. Initially, we always thought that we have to suppress LH, which normally occurs in PCOD patients. So that is no longer much recommended. I think giving them metformin is one way when we can help the patient. So even that is not a very well established technique. We had an idea, we always thought that in case the woman has got a luteal phase defect, when after her ovulation, the endometrium is not forming well, we always thought that she's got a luteal phase defect, and we always thought about giving her some support in the after her ovulatory period. So thinking that she's got an LPD, the second part of the cycle is unsatisfactory. But nowadays they say that it is inconsistent. First of all, we should not try to diagnose LPD only. So LPDs were normally diagnosed by carrying out some hormonal assays, and it was diagnosed by carrying out endometrial biopsies. This is no longer recommended, and the data says whatever we have learned that there is not much of indication of giving some sort of luteal phase support to the patient in form of progesterone. It is not very important, not very helpful. So then there another condition is that there can be some amount of uterine anomalies which can occur, and uterine anomalies they occur in around nearly 40% of the patients, and they lead to late recurrent miscarriages. So when a woman has got when we find that she's having multiple abortions, we should always do 3D ultrasound of the uterus, or we can carry out her hysteroscopy, or even HSG can give us some idea. So we have to rule out any uterine septa, and that's very important for all of us. And in case we find a septa which is more than around 1 centimeter, the septa must be reduced. We can also give them cervical ensaccalage in case they're having recurrent abortions, and this can be helpful in certain cases. Now, in case a woman has got submucosal fibroid, in case you have had abortions and you've had a polyp or a fibroid or a septa, I think these have to be reduced before we move ahead and do more IVF for you. So, in case a polyp is very small one, or a fibroid is a very small one, they say that we may even avoid doing surgeries for such people. But in my practice, in case I get a uterine septa or a fibroid, I always feel like I always normally carry out the surgery to have a clean uterine cavity. Now, in case the couple has got the lady has got multiple recurrent abortions, and they have a fibroid in the myometrium, that is called an intramural fibroid. Here I would say that there is no indication of carrying out fibroid removal. Fibroids we normally remove when the fibroid is either very big and it is compressing upon the uterine cavity, or the fibroid is in the uterine cavity itself, when we call it a submucous fibroid. There is insufficient evidence that removing the fibroids which are intramural, which that will lead to better outcome in our cases. So that should be avoided. But in case the fibroids are submucosal, they are lying in the uterine cavity, yes, there is a big evidence that we should be removing them. Then the infections part I've already covered with you, that in case we are able to treat the infection in the uterus or in the cervix or in the vagina, the chances are that the incidence of recurrent abortions may even reduce. The chances of late miscarriages or preterm births will also reduce. Then many people who have tuberculosis, they feel that TB can lead to abortions, but now we have data that TB normally doesn't lead to recurrent abortions until there are uterine septa or uterine adhesions. But TB by itself as an infection won't lead to recurrent abortions. Coming to the thrombophilic defects, which are actually pretty common in our practice. These can be inherited or these can be acquired ones. So the inherited ones are something like homocystinemia, then it can be protein C, protein S deficiency, and the acquired ones are normally APLAs, and APLAs we know they can be anticardiolipin or antiphospholipid antibodies. Now we know that whenever we have thrombophilia, there's a high chance of the couple of the people getting the villus infarcts in the placenta. There can be single or multiple infarcts. There can be necrosis of the decidual vessels. There can be placental hypoplasia or spiral artery thrombosis. All these things can occur. So all the women who have got recurrent abortions, it is recommended that they can undergo APLA screening by carrying out anticardiolipin antibodies, and they can also undergo LAC, lupus anticoagulant assessment. So it is recommended that we don't carry out assessment of protein C or protein S or hyperhomocystinemia in the women who have got one odd early first trimester abortion. That is not recommended. But in case the women with second trimester miscarriages, they come to us, we can definitely carry out inherited thrombophilia screening in the form of factor 5 leadin deficiency, protein C, protein S deficiency. These can be also carried out. Then how do we treat them? Whenever a couple comes to us with recurrent abortions, we can treat them by giving them low molecular weight heparin, which would have been given to you in case you have had this problem. It works very well. So normally we combine low molecular weight heparin with the aspirin. So in case we combine both the drugs, the outcome becomes better. So then we have to understand that it's very easy to treat and APLA syndrome in case we diagnose it at the right time, and in case we start the heparin at the right time. Normally we start heparin when the beta HCG test comes positive, and aspirin can be started even 1 month before we carry out the IVF for the patient. It gives us good outcome. So to diagnose APLA, as we have just discussed, we can carry out lupus anticoagulant, we can carry out anticardiolipin antibody syndrome assessment. So we can carry out IgM or IgG antibody assessment, and this can be routinely done. It is not very expensive, but it gives us, and it also gives us good outcome when we carry them out. So moving further, APLA we have understand, and then many people give steroids. So we have to understand that there is not much role of giving steroids to the people. That can be avoided. In case we give somebody heparin in the dose of 1 milligram per kilogram body weight, or we give them aspirin 75 to 100 milligram per day, that will do them good, and that is a good way to handle the uh, APLA syndrome in the people. Now, when you go to the doctor with these problems, they order for multiple tests, and these the tests can be like HLA compatibility test, NK testing, cytokine assessment. But these tests are not actually recommended, and doing something looking at TH1, TH2, interleukins, CRPs, they are not recommended tests for the people who have got recurrent abortions, and these can be easily avoided. So for the therapy, very common therapy is lead therapy. So lead therapy is also not recommended. So in case you have been told lead therapy, I always say that you must consult a second doctor. And in my opinion, lead therapy and these sort of exotic testings can be avoided, and they don't help us much, and they have got more adverse side effects. Then many doctors we are adding after in case we have conceived we add progesterones. So the progesterones can be given vaginally or orally. They do help. So they do help by creating more favorable milieu in the body. So in case you have got recurrent abortions, taking some amount of progesterones can be helpful, and they are quite safe also. So they do increase the pregnancy rate, but in case you look at the data, it says that it has got insufficient evidence. But still, we are giving it no harm in taking some amount of progesterones when we are having such problem. So these are the things which came to my mind and I have spoken. So the take-home message would be that in case you are having recurrent abortions, or in case we deal with the people who are having recurrent abortions, uh, what we have to do is rule out common conditions. The common genetic problems can be ruled out. We should rule out the common uterine abnormalities, rule out APLA syndrome, treat them with heparin, give them folic acid, give them aspirins. Uh, in rare cases, when we are having multiple problems, some people do recommend undergoing PGD where embryo biopsies are being done. So these are multiple options available to us. But definitely going in for exotic therapies like lit therapy, or looking at the cellular status of the body, the immunity of the body, that is not recommended, and these can be easily avoided. So now after this, I've ended my talk. In case you have any queries, you can always ask me. So I'll come to few. I've got 8 queries which are with me presently. I'm going to them. So I've got a query from Miss Sonali Bakshi. Uh, she ये कहती हैं कि हेलो डॉक्टर, मेरा आईवीएफ ट्रीटमेंट दिल्ली से चल रहा है। हॉस्पिटल वालों ने मुझसे एम्ब्रियो टेस्टिंग कराने के नाम से पैसे लिए, और ऐसे ही बहुत सारे पैसे मांगे, पैसे लूट लिए, whatever. Sonali ji, what I can make out is that you've had a bad experience with the doctors and you are feeling hurt. So the main aim of our having such sessions with you all is to educate you, and so that nobody is able to cheat you. Normally, all doctors, they want to help you and they do the right thing. But in case you feel that you need a second opinion, you are most welcome to contact us. You have our number. I'm working at CK Birla Hospital at Gurgaon. You can always call us. You can WhatsApp me or email me. We'll take your queries and we'll be able to help you. But I think that don't take much of stress and start your life fresh. Then I've got a query from Jitendra Suhag. जितेंद्र जी जानना चाहते हैं कि मेरी वाइफ का बार बार मिसकैरेज हो जाता है। मेरे पास एक 6 साल की लड़की लड़की है। क्या करना चाहिए? मुझे जानकारी चाहिए। सो जितेंद्र जी, मैंने आपको अभी जो चीज़ें बताई हैं, हमें वो सब चीज़ें करनी चाहिए। और एबॉर्शन, आपके पास एक बेबी है तो आपको और भी बेबी होगा डेफिनेटली। सो इन केस यू हैव एन एबॉर्शन, आई थिंक जो टेस्ट हमने आपको लिख के दिए हैं, जो आपको बताए हैं, वो सब टेस्ट हमें करने चाहिए। और ऐसा करने से आपको बेहतरीन रिजल्ट मिल सकता है। ये चीज़ें हमें करनी चाहिए। If you need any help, you can always contact us. But foremost of all, have faith on God, have faith on yourself. You're not having a major problem. It's a chance that you're having these recurrent abortion. I think things will improve, and be in touch with us. मधु जी जानना चाहती हैं, मधु धिका जानना चाहती हैं, मुझे 2 लड़की हैं, मुझे क्या लड़का हो सकता है? So she wants to know whether she can have a male child, as she already has 2 female children. So for her, I would like to say that this is called sex determination, which we don't carry out in our country or anywhere. Is not recommended. So I think that such sort of practice is wrong and unethical. Our country laws, they don't permit us to carry out any amount of sex determination by doing PGS or PGD. So these things should not be done. So I recommend you not to get into this sort of a thing because it won't help you. इससे आपको फायदा नहीं होगा और आपको नहीं करना चाहिए. Then I got a query from Pankaj Thakur. He wants to know something more about IVF, how the IVF is being done. So Thakurji, you can always come to our Facebook page and leave your number to us. We'll call you back, or you can come to CK Birla Hospital and Gurgaon. We'll try to help you whatever way you want our help. Then there's a query from Vipin Munjar. Vipin ji जानना चाह रहे हैं कि why is the fresh why are the results better in the frozen cycle as compared to the fresh transfer cycle? So, it's a very good query, Vipinji. This here we have to understand that when we carry out fresh embryo transfer, there can be some sort of derangement in the endometrial growth. The endometrium may not be very receptive for the implantation of the embryos. So nowadays we are always preferring to carry out frozen embryo transfer when the embryos are then thawed after a few months or 2 months, and then they are implanted back. So we have found that in case we carry out fresh embryo transfer, the chance of your success will be around 40-45%, and in case we do frozen embryo transfer, the chance may even touch 60%. So this is all about the endometrial receptivity and the hormonal imbalance which occurs when we carry out fresh embryo transfer. So after this, we have got a few more questions, and these queries they come from Dinesh Agarwal. He wants to know that how much is the expenditure of carrying out PGD. So the charges of PGD, they vary from lab to lab, but you have to understand that in the PGD there are various components. One is the IVF. In IVF, we have to spend the amount of money which we spend for IVF at every lab. It may vary from 1 to 1.5 lakh rupees. On that, we add some amount of money for embryo biopsy. Then we add around rupees 30,000 for the embryo biopsy procedure. And after that, we add around 10 to 15,000 rupees per embryo being biopsied. So in case you carry out PGS or PGD, what I understand is your expenditure will touch somewhere around 2 lakh rupees. That's the approximate amount of money you will pay when you undergo PGS or PGD cycle. I think that's all from my side. In case you have any queries, you please keep in touch and keep calling us, and we'll give you all the help required from your side. So thank you so much. It was nice being with all of you, and hope to meet you next week with some new topic. Till then, goodbye and have a nice evening. Thank you.